Hello, and thank you for joining us for our webinar on caffeine and headache. Tonight's presenter, Dr. Rachel Coleman, is the Headache Fellow at Icahn School of Medicine at Mount Sinai. She completed a neurology residency at University Hospitals, Case Medical Center in Cleveland, Ohio. Prior to residency, she attended medical school at the Medical School for International Health in affiliation with Columbia University Medical Center at Ben Gurion University of the Negev in Israel. Dr. Coleman's interests include medication overuse headache and headache and palliative care. Dr. Coleman, would you like to begin?
Thank you. Thank you, everybody, for attending this lecture and having interest in headache, as well as caffeine and headache in particular. Today's discussion, we're going to look into caffeine. As I'm sure many of you are aware, caffeine is a complicated topic. Many people will give you many conflicting information regarding it. So I hope at the end of this lecture you'll have a little bit of an insight into what exactly caffeine is, how it can be used safely, and when to use it and when not to use it. Next slide, please. So caffeine, or it's otherwise known, 1,3,7-trimethylxanthine, it's a naturally occurring stimulant. It's found in many foods such as coffee, cola, tea, chocolate, among many other things. And it also can be created in the laboratory and added as an additive to foods as well that is not naturally occurring in. Next slide, please. So, approximately 90% of people in the world use caffeine in one form or another in a given day. Some countries use more than other countries. In the U.S., about 80% of adults consume caffeine every single day. And the average intake for an adult is approximately about 200 milligrams per day of caffeine. Next slide. So in terms of understanding where we get our caffeine from and how much we are consuming with each caffeinated beverage, I think it helps to know that about a cup of coffee, a 6-ounce mug of coffee, contains anywhere between 60 and 100 milligrams, and that really depends on how you brew it, how much caffeine is in the cup. Decaf coffee, for those of you who choose decaf, has a very tiny amount of caffeine, about 2 to 5 milligrams. Your caffeinated sodas, cola, Pepsi, and the like, they have about 30 to 60 milligrams per 8 ounces. Those are generally consumed in a little larger volume, generally because they are cold. When you have a warm cup of tea, it's about 40 to 80 milligrams. Again, this depends on how you brew it. If you steep the tea longer, you will end up with more caffeine in the tea. And then, of note, common headache medications that have caffeine added to them, depending on the substance, some of them contain about 16 milligrams, and some contain as much as 65 milligrams of caffeine, so about just as much as a cup of coffee. For those of you who were ever in college and wanted to pick me up and bought over-the-counter caffeine supplements, those actually contain a whopping 200 milligrams of caffeine, so as much as 2 cups of coffee. Next, please. So what's important to know about caffeine, it's lipid-soluble, means fat-soluble, which means it can get into the brain. It can permeate the blood-brain barrier. Caffeine is very fast-acting. I'm going to refer to it as a drug because it is a drug. It is a substance that we take for a given effect. It is very fast. Within 6 to 8 minutes after you swallow your cup of coffee, it becomes active, and it becomes fully active within 30 minutes. And this is something you probably have all noticed when you have a cup of coffee in the morning. You start to feel more alert very quickly and have maximum effect about 30 minutes. Caffeine has a half-life, and half-life is a term we use when we're talking about drugs, and we're talking about when half of the substance has already been broken down by our body and half of it is left. So its half-life is 3 to 5 hours, meaning caffeine, most of your caffeine hangs out in your body for approximately 3 to 5 hours after you've taken it. And it is eliminated, meaning we clear it in the kidneys. Someone who has kidney dysfunction might take a little longer to clear the caffeine. Next, please. So as you are most likely aware, caffeine is a stimulant. And the interesting thing about this stimulant is we're trying to figure out how it works. How does caffeine give you this up feeling and this energy? So it has to do with the brain and brain chemicals. Now, adenosine is a chemical that's created in the brain, and it binds to adenosine receptors. And when adenosine binds, it causes drowsiness. It slows down nerve cell activity. And the way it slows down nerve cell activity is a complicated system of second messengers and other chemicals within the cell itself. In the brain, the binding of adenosine to the adenosine receptors also causes blood vessels to dilate. The interesting thing about caffeine is that biochemically, it looks just like adenosine, and it can bind to the adenosine receptor. Next slide, please. So when the cell has caffeine bound to it, it can no longer recognize adenosine, and adenosine can no longer bind. So instead of slowing down by the addition of adenosine, since adenosine isn't there, and caffeine works on these receptors differently, your nerve cells speed up. Caffeine also causes the blood vessels of the brain to constrict, to get smaller, and this is because adenosine, which usually dilates it, isn't able to be present. Next slide. So caffeine's effect on the brain is to increase the neuron firing, increase the nerve cell firing. The pituitary gland, which is a hormone receptacle, a gland in our body that produces hormones, senses this increased firing activity in our brain and misinterprets it as somewhat of an emergency. When it sees the increased firing, it releases a hormone that many of you might be very familiar with. This hormone is adrenaline or epinephrine. So that tells the adrenal glands you need to produce adrenaline. So it's a number of different body systems that are coming together to produce this drug. Adrenaline is the fight or flight hormone. It's what makes you very active and able to fight off when something deleterious is happening to you. And besides for getting you up and ready to go and fight, adrenaline has a number of effects on your body, which is in essence the effect that caffeine has. So what adrenaline does is it dilates your pupils enlarge, your airway opens up to allow you to breathe more air to do this strenuous activity you're about to do, your heart beats faster, blood vessels on the surface of your body constrict so that blood flows away from possible bad things such as cuts. It increases your blood flow into the muscles which you're going to need to use to run away. Your blood pressure rises, the blood flow to your stomach stops, kind of the same way it flows away from your periphery. You don't need to digest when you're in an urgent scenario. Your liver gives sugar to your bloodstream so that you can have energy, and your muscles tighten up ready for action. So that's what adrenaline does when we are frightened, scared, or anxious, and also what is the byproduct of using caffeine. Next slide. By the byproduct of all what caffeine does is part of the side effects of caffeine that we don't enjoy. We like being alert, we like feeling ready to go, we like not being sleepy, but we don't like the fact that it relaxes the stomach in such a way that can cause increased acid. So you're predisposed to get gastroesophageal reflux disease because it relaxes the sphincter that keeps the acid in your stomach. The other thing that it does is it increases gastric hypersecretion of acid, which can make you quite susceptible to ulceration. It is also a diuretic, meaning it increases urination, and that can be harmful if you're using very high dose or you're pretty dehydrated. It can further dehydrate you. Next slide. One thing that's very often talked about is caffeine withdrawal, and this is where it gets, I would say, more interesting. Caffeine is really different than the other agents of abuse that you might be familiar with, and you might be familiar with having withdrawal symptoms. Caffeine doesn't work the same way in the brain that cocaine or opioids or alcohol. It doesn't activate the same centers of pleasure and reward. It activates different centers, so it doesn't act the same way in your brain, and we don't seek it in the same way. And in that sense, we don't withdraw in the same way. Some people do experience withdrawal symptoms when they stop using caffeine, but this is not true of most people. The people that do experience withdrawal symptoms tend to know them very well. It can be headache, irritability, sleepiness, confusion, palpitations, nausea, anxiety, tremor, or even raised blood pressure. Next slide. There's a very distinct category called a caffeine withdrawal headache. And this meets diagnostic criteria when it's bilateral, meaning both sides, and or it's pulsating. the person, in order to get this kind of headache, really needs to be using more than 200 milligrams for at least 2 weeks and then have that use interrupted or delayed. The headache develops within 24 hours after the last caffeine intake, and it really is resolved within 1 hour of taking 100 milligrams of caffeine in any way you'd like to dose yourself. And generally, this headache will resolve within 7 days after total caffeine withdrawal. So that's a very different entity and very specific entity that does not occur in most people. It's important to know about toxicity and overdose. High doses of caffeine, we're talking 250 to 500 milligrams, can give you a sense of restlessness, nervousness, insomnia, and tremors. It can be quite deleterious and really uncomfortable for most people. If someone were to ingest about 10 grams, it can be fatal. Overdoses are seen relatively infrequently, but when they are seen, it can cause a syndrome that can result in seizures or heart instability, and it can be very dangerous. What I would like to note is that you need to really exercise caution when using energy drinks. Energy drinks tend to have around 200 milligrams or 150 milligrams of caffeine. It's a lot of caffeine in one dose. Frequently, when these are consumed at raves or parties, they're consumed with alcohol, which further limits people's ability to function normally and to behave appropriately and to respond to symptoms correctly. It can lead to dehydration. It can be very dangerous. So in that instance, that's where most people get into trouble with caffeine. Next slide, please. So what I think we're probably all really wanting to hear about is how caffeine is used in pain relief. And the most common way it's used is as an adjuvant. So what that means is that on its own, it is not incredibly effective, but used together with other pain-relieving medications can be very effective. So caffeine is added to other medications such as acetaminophen or Tylenol, aspirin, indomethacin or Indocin, prochlorperazine, compazine, and it works in twofold. It enhances the absorption in the stomach, and then makes the ability of these drugs to work faster and then provide earlier headache relief. As well, there's some sort of analgesic effect and pain-relieving effect on its own that we don't quite understand. The studies that are shown on these medications when they're combined with caffeine show benefit in tension-type headache as well as migraine headache. So both the different headache types show relief when caffeine is used with aspirin or acetaminophen or indomethacin together, more relief than either of those substances when they're given alone. And one interesting thing, there was one study that I was looking at recently that said when you combine any of these drugs with caffeine, you use less of the analgesic drug. So in order to receive the same benefit in headache relief, you would use less Tylenol when Tylenol is combined with caffeine. Next slide. So what's interesting is how this works. So as we discussed before, caffeine constricts the blood vessels in and around the brain, and that's thought to be helpful in headache because current data suggests that the blood vessels at the beginning of a headache start to enlarge. So constricting those blood vessels can delay, postpone, or stop the headache process. Next slide. This all sounds really great, and it seems like it's a really great drug, and you might be wondering why, A, not every doctor recommends it, why you've heard some negative things about it, and medication overuse headache is probably the primary reason why most physicians, most headache specialists are reticent to prescribe medications that have caffeine in them. So medication overuse headache is a new entity. It is different than a tension-type headache or a migraine headache. It is a headache that occurs when there's an interaction between a therapeutic agent, i.e. ibuprofen with caffeine, that's used excessively, and a susceptible patient, i.e. overuse of acute agents causing headache in a headache-prone patient. For the diagnosis of medication overuse headache, patients must have headache that meet these criteria. It must be present for more than 15 days of a month. They have to be regularly overusing for greater than 3 months one or more drugs that are taken for acute or symptomatic treatment of headache. The headache that is developed is markedly worse during the time of the medication overuse, and it resolves or reverts to its previous pattern within 2 months of stopping the overuse medication. Next slide. In some cases, the problem begins when a patient is taking immediate relief medication, or in some instances, medications, at the slightest hint of attack. This approach can evolve into a habit of treating in anticipation of the headache, even when no pain exists. We find in those people the headache and medication cycle becomes self-sustaining, where they take medication, then get a headache, and take more, then they take more medication, then they get a headache and take more, so they take more medication. And the head pain eventually becomes chronic, and the treatment with the immediate relief drug becomes the cause of the head pain. And I like to explain to people that pain begets more pain, and the body is very sophisticated, but in terms of the headache-prone patients and those that already have an episodic headache disorder, when the level of this drug gets lower in their system, they feel their brain is looking for the drug in essence, and that looking is another pain signal to the brain, and more pain gets more pain, and then their headache continues, an unfortunate vicious cycle. Next slide. So there are actually two types of headaches that we treat with caffeine, and caffeine is the agent of choice. And I just want to spend a few minutes discussing these two types of headaches. One is the hypnic headache, and one is low pressure headache. So we'll start with hypnic headache. So hypnic headache is otherwise known as alarm clock headache, and this is because for many people it occurs at the same time of night every night. It's either 2:30 or 4:30, the same for each person. And these headaches are episodes of dull head pain that develop only during sleep and awaken the sufferer from sleep. It's almost exclusive in later life. We do not generally see it in patients that are under 50. It's pretty frequent. It can be greater than 15 days per month, and it persists for at least 15 minutes after awakening and lasts no longer than 3 hours, although there's always exceptions to every rule, and occasionally it will last a little longer. About 2/3 of hypnic headaches occur bilaterally, so it's mostly bilaterally, but occasionally some people have it only on one side of their head. Next slide. So the headaches are mild to moderate in intensity, but some people, about 20%, do say it's severe. And when it's severe, it makes the diagnosis a little harder. Most people report throbbing pain or pain that has migrainous features. It's can be very common. What's really important here is to exclude mimics. Make sure this patient, A, does not have a tumor or doesn't have really high blood pressure overnight that's causing them to wake up with headaches. Caffeine is the preferable first-line therapy for the hypnic headache, and it's really interesting. You advise the patient to have a cup of really strong coffee when they wake from a headache, and as well have a cup of strong coffee before going to bed. For some people, the cup of coffee prior to going to bed is enough to have them no longer wake up with headache. Some people still have headache, and the cup of coffee taken when they have the headache will relieve it. The problem with this treatment is that it can cause pretty serious sleep problems. You can imagine having caffeine late in the evening makes it harder for people to go to sleep. However, most people seem to do just fine and are able to sleep even after that one cup of coffee. For some people, when they wake up with the headache, they don't want to start making coffee, and they can have caffeine-containing analgesic pills at that time. But those are somewhat risky as well, as they carry the risk of medication overuse headache. Anytime you combine more than one drug, the risk of medication overuse from each substance goes up. Next slide. So what's interesting is that typical drugs used for headaches, like nonsteroidals, opioids, 100% oxygen, which is used in cluster headaches, which is similar but a different headache disorder, and acetaminophen really aren't effective. Triptans, which some of you may know is used in migraines, as well, is somewhat effective. When people do not respond to caffeine, we often go to lithium. However, lithium has a lot of side effects, and it's a hard-to-tolerate drug, though very effective. If you don't want to try lithium, indomethacin is also an option, and it has been shown to help in some people. And what's important to realize is that we really think that this is a disorder of the sleep-wake cycle. Something is very different in the person's sleep-wake cycle, and getting it back on track with treatment is important to manage this hypnic headache. The next headache that we want to discuss is low-pressure headache. So low-pressure headache can be found due to a number of causes. Frequently, we see it after a spinal tap, where there's removal of cerebral spinal fluid, and after that, the patient develops headache. Or subsequent to the spinal tap, there is leakage due to dural puncture, and the fluid slowly leaks and they develop headache slightly more remotely from the initial tap. As well, there can be a spontaneous leakage of fluid due to either a tear in the setting of trauma or a cyst that might rupture. This loss of fluid, the fluid that surrounds the brain, this fluid flows around and cushions the brain and reduces the pressure around the brain. When the fluid is lower, the brain will start to sag downwards, and this stretches the surrounding tissues and nerves. And we feel that the stretching of the tissues and the nerves is actually what causes the pain. So what's interesting about low pressure headache, it's generally not present on waking up. Most people wake up headache-free, and the headache worsens throughout the day. It's generally relieved by lying down. Even within a few minutes of lying flat, the pressure normalizes around the brain. The nerves are no longer pulled, and the pain resolves. It can take only minutes or even up to an hour for the pain to return when the patient is again upright. Associated symptoms with this headache can include a decreased appetite, nausea, vomiting, vertigo, a sense of motion, tinnitus, ringing in the ears, or even double vision. If the headache occurs soon after an LP, no further workup, a lumbar puncture, no further workup is needed. We really know the mechanism why this headache occurred, and we'll just go right ahead to treatment. If the patient has symptoms of this kind of headache and there hasn't been any lumbar puncture or epidural spinal procedure performed, usually we'll perform an MRI with gadolinium, that's contrast dye, to look for a very specific finding called pachymeningeal enhancement, which when the brain is sagging, there's an enhancing along the areas of the meninges. Next slide. Treatment at first is symptomatic. We have them lie flat, drink lots of fluids to increase the volume of the cerebrospinal fluid, and caffeinated beverages. In some cases, we even give IV caffeine. So the presumed mechanism for why this occurs is thought to be increased cerebral artery vasoconstriction. So the arteries in your brain are vasoconstricted, and that means less blood flow to the brain. Less blood flow to the brain means less brain volume and less pressure pushing down on those nerves, and that's how we think caffeine works. It may as well increase CSF production. The interesting thing about the caffeine is that it doesn't cure the tear of the hole. It just buys you time where the patient feels well for the tear to close on its own. If the caffeine doesn't work, we can do a procedure called a blood patch, which is one of the more interesting procedures that is done in medicine. And the patient's own blood is injected right in the area where you would have done the lumbar puncture in the lower spine and put in the epidural space. And the blood basically clots up the hole on its own. And that's the safest and really easy way to stop the problem. It's generally very effective for most people. Next slide. So we've come to the end for the formal part of this talk. I thank you very much for listening, and I look forward to answering your questions.
We actually do have a question to go back over the medication overuse slide. Would you mind doing that very shortly?
My pleasure.
Or just briefly?
So medication overuse headache. One of the hot topics in neurology in the sense that it is it's not actually very common, but it's a very frequent reason for patients to come and be seen by a headache specialist, since it's a very hard to deal with problem. And we usually think of medication overuse as an interaction between a therapeutic agent, means a drug the patient is taking, and using it excessively, more than 3 days out of the week, and a susceptible patient, meaning the patient has to be a headache-prone patient. In patients that don't have headaches, we don't find this concept of medication overuse. In order to diagnose medication overuse headache, to meet ICHD criteria for the diagnosis, you must have headache more than 15 days a month. You must regularly overuse one or more acute medications for headache for 3 or more months. the headache must be worse during this period of overuse or become worse during this period of overuse. And the headache resolves to its old pattern within 2 months after we discontinue the overused medication. So it'll sometimes take up to 2 months for the patient to go back to their previous headache frequency.
All right. Our next question actually is comes from Tan, and she's wondering, what is the purpose of adenosine in the body?
So that's an interesting question. Adenosine in the body has multiple roles. It builds up throughout the day in our brain and kind of helps us to turn our bodies off and go to sleep. It is used very, very, very widely in our bodies, not just for this one purpose. If you are aware of an agent called ATP, it's the energy cell of our body. It actually has adenosine in it. But in this particular instance, where caffeine is an agent that is a stimulant, it's replacing the adenosine in the adenosine receptor and that location. Adenosine is so widely used that it would be, you know, a biochemistry lecture to talk about adenosine in full.
All right, and another question coming from Lori is, physiologically, how does caffeine increase the strength of a medication or the analgesic effect of a medication, and how quickly does it work?
Okay, that's a really good idea. So physiologically, what we understand is because of how caffeine is dissolved and absorbed really quickly in our stomach, it increases the stomach acid, it breaks down the medication in your stomach much faster than it would have broken down on its own. So what it does is kind of like a boost or a jolt to get the medication working. All these medications that we take for pain take a while to be absorbed into work. This jump starts the absorption of the medication. There was a second half of the question wasn't there.
Gail asked,
yeah.
Oh, I'm sorry. I believe it was just how quickly does it work?
Oh, so 6 to 8 minutes for the beginning of the caffeine to start to be dissolved in the body, and that'll start to get the headache medication to work, and probably max effect within 30 minutes.
Gail asks, does caffeine enhance the effectiveness of triptans as well?
You know, that's a really interesting question. I'm trying to remember if I saw a paper on this. I believe not. I believe caffeine does not enhance the effect of triptans, but I must admit I am not entirely sure about that. My suspicion is no.
All right. And is there any reason to believe people with chronic headaches would be more sensitive to caffeine?
That's an interesting question. I think that really depends on what is the person's use of caffeine. Well, we didn't discuss at length with caffeine tolerance, that there is some idea that after using caffeine regularly at a certain dose, it doesn't have the same effect on the person, and that someone who is new to caffeine will have a much greater response to the caffeine. So someone who is using a lot of caffeine every single day may not notice its effect as much. Should they wean the caffeine down and then try it again, they may notice a more increased effect. Using anything episodically will give a greater oomph. So I don't think it has to do with the person's headache history, more has to do with their use of caffeine.
And Claire asks, how would you get off medications that are causing rebound headaches or medication overuse headaches? How long does it usually take? Is there anything to take while you are not taking the medication to help with the pain?
Those are really, really great questions. It really depends on what medications you're using. Some formulations that is used frequently for headache unfortunately has agents in them that are addictive. And if you are talking about one of those medications that has an addictive substance in it, such as an opioid or a benzodiazepine or something like butalbital, then I'd want you to talk with your doctor about safely coming off those drugs, because that should be done under a doctor's care, just so that it's done safely and slowly. If someone is overusing caffeine with Tylenol that doesn't have any other component to it, then they can simply on their own cut down. And it has a lot to do with willpower. That for most people who are overusing the medications, they have really, really severe headaches almost every day. That's why they're using the drug. So they have to be able to help themselves to cut back their use. Frequently, when someone's overusing heavily and they need help with cutting back their use, we can either admit them or do outpatient IV infusions of headache medications to kind of take away the difficulty in the first few days of coming off these drugs. So my recommendation for anyone who has this issue is to seek advice of a neurologist to see if they can help them through the process. It's not as complicated as it sounds, but there's many other medications we can give to support the person that are safe during that time frame.
All right, our next question is, if someone has a low-pressure headache, how much and how frequently would you recommend they have caffeine, and at what dosage? Also, could it only be low-pressure headache if the headache clears up 100% when the patient lies down?
So I'll answer your second part first. There are other headaches that may clear up in that fashion, and if the patient has a symptom of a low-pressure headache, then they haven't had any history of trauma or lumbar puncture, it warrants workup to make sure they're not missing anything, any cysts in the back of the brain that might give some similar findings and that we may treat differently. However, the most frequent cause of someone who really has a headache when they, after about an hour or so of being up and relieves when they're lying down, is the low-pressure headache phenomenon. And in terms of how much caffeine to use, I don't think there's any absolute data. It really depends on the person. I would drink a strong cup of coffee and then see how you feel. If that's not working, have another cup of coffee. People who after two to 3 cups of coffee a day really aren't feeling well, we can give them intravenous caffeine. Sometimes we give up to 500 milligrams IV caffeine, and to see if the big jolt of caffeine in that fashion helps. And if caffeine isn't working, we really need to think about other, and also increasing the fluids and just kind of laying low for a day or two. If that's not working, we start to think about other options.
Along those lines, Janice asked, in chronic headache or chronic daily headache, is there a recommended limit on daily caffeine use?
So chronic daily headache is a different diagnosis, which we didn't discuss, but in terms of if someone has daily headaches, what I would say is, for someone with daily headaches, having caffeine every day alone on its own may be a trigger for you. Then again, it may not. So it may be worthwhile, if someone's having everyday headaches, to cut their caffeine down slowly so that they don't get a withdrawal headache, and see what their headaches do when they're done. If they're the same frequency as they were before and you really miss your 1 cup of coffee a day, I don't think there's any harm in keeping the 1 cup of coffee a day. However, if someone has a daily headache and is taking caffeine pills with other analgesics such as Tylenol, Fiorcet, or the like, that's when you start to be really concerned that caffeine is the cause. You know, I always try to advise my patients to kind of cut down their caffeine slowly so they don't get a caffeine withdrawal headache. And generally, if you cut it down over a few days, substituting decaf for your caffeinated beverage in half portions, if you can come off the caffeine pretty seamlessly without getting any symptoms.
We have a popular question in regards to medication overuse headache, and that's if you alternate pain relievers such as aspirin and alternate aspirin with Aleve or something along those lines, is that helpful in preventing medication overuse headache?
Probably not enough as everyone would like. You know, the medications that are working in that way tend to all have similar effects. It's worth talking to your doctor and going through each person's specific case to see how we can best help the person, you know, do better and cut down and cut back and discuss their headache use. But unfortunately, you know, alternating, you know, Aleve with ibuprofen really doesn't work very well in terms of preventing the medication overuse headache. Although it may be a good idea to switch days that may be protective somewhat. You know, we're talking about, you know, 2 not good options. If not, we're not talking about a really advisable option here.
We have a question coming from Lori in which she asks, why do migraine medications frequently contain caffeine? I know that was kind of covered in the presentation, but she says that if she drinks anything, she says that if she drinks anything that contains caffeine, even decaffeinated coffee, she ends up with a migraine. But if she takes medication such as Fioricet, which has caffeine, and that's mixed along with Dilaudid, her migraine goes away and lessens quite a bit. Why would it be that the medication that contains it doesn't cause a migraine for her and actually relieves it, but caffeine otherwise triggers a migraine for her?
So caffeine is a frequent migraine trigger for people. For some people, different foods, beverages are the trigger, but it's not the same for every person. So it sounds like that she might have a migraine that is triggered by caffeine. Or it could be a different substance. It'd be wise to do a really careful headache diary and see if it's the caffeine or it's the tannins in the tea or whatever she's drinking that may be the actual trigger there. In terms of why the combinations of medications help, it's possible that other parts of the combo medication are helping her and they counteract the caffeine effect. Anytime you use a combo medication, there's an even higher risk of medication overuse headache. Now, of course, they're all pretty safe and really can be very effective if used properly, if used no more than twice a week, max 3. After that, they start to cause their own problems. So cautious and careful use, knowing the risks and benefit of each substance is really important. And if caffeine is a headache trigger for her, I'd advise her to stay away from any substance that has caffeine in it, even if she generally finds it helpful. There are other combos that don't have the caffeine in it, and she can look for those.
Right, and Tanya asks, if caffeine doesn't make your chronic headaches worse, can you have a few cups of coffee a day, and would that help with the absorption of pain medication?
If you do not have, if you've already done the test and kind of come off coffee and found that it doesn't hurt you, then having 200 milligrams or so 1 or 2 cups of coffee a day is probably acceptable. However, anything more than that, you're risking a stomach ulcer, which is a pretty deleterious side effect. So be cautious not to increase your caffeine intake. There's other safer medications that can use to increase the absorption in your stomach if that's what you really feel is a problem. Someone who has daily headaches, we don't advise them to take daily pain medication, so you have to be careful there.
All right, that actually looks like it's all the questions that we have for today. So thank you everyone for joining us, and thank you Dr. Rachel Coleman for also running this webinar.
Thank you everyone very much.